A widespread rash that is composed of small macules and papules that may coalesce, and they coalesce usually on the central trunk and more commonly on dependent areas. So the back will coalesce first before the chest and before the arms and legs will coalesce.
If papules coalesce, do they become a patch as opposed to a macule?
Yeah, there'll be a patch or a plaque. If you could feel it, it would be a plaque.
Right.
If you can't feel it, it would be a patch.
Hence measles-like, because they all coalesce.
Exactly.
Got it.
So when you see someone who has a morbilliform eruption, there are a few things to think about. And the first one, and importantly, would be measles. And again, because of vaccination trends, measles has had a recurrence. The next thing is also infectious, which would be mononucleosis, which is an EBV or Epstein-Barr virus driven process. And oftentimes someone who has mononucleosis might get a penicillin-based antibiotic, and that brings on the rash in someone who has mononucleosis. The next diagnosis that can give you a morbilliform rash is just a run-of-the-mill viral exanthem. So this is
like PEDS 101,
exactly.
Viral exanthem. You
right.
have a cold and now you have a rash.
A lot of different viruses that can give you this morbilliform eruption, and they are more common in kids, but sometimes adults can get them too. The next thing now is drug reactions, and these can really mimic this morbilliform eruption or a measles-like eruption. And a lot of different drugs can cause this, but very commonly it's antibiotics that a patient might have received within the past week or 2 or 3. These types of reactions actually require sensitization. So the first time you receive a drug that gives you a morbilliform rash, it takes upwards of about 2 weeks, at least 1 week, to actually get the reaction. But let's say it's the second exposure to a particular drug that gives you this reaction. Now you're going to get it much quicker. So you need the sensitization for about 1 to 2 weeks, but if you get the drug a second time, it will happen much quicker within a few days. Lastly, now we're going to get to things that are less common, but more of your red flag diagnoses. So the first thing is early graft versus host disease. So if a patient has recently had, let's say, a bone marrow transplant from an allogeneic source, so someone other than themselves, early graft versus host disease will start to look morbilliform in nature. It can take different appearances later on in the course of the disease, but it looks morbilliform immediately. And lastly would be something we group into this evolving badness.
Something we call evolving badness.
Yes.
It's the ticking time bomb waiting.
Your child either has a viral exanthem, NOS,
or evolving badness.
We'll see you in a couple days.
So we'll talk a little bit more about things like Stevens-Johnson syndrome or toxic epidermal necrolysis, but that's really what we mean by evolving badness. And the only reason why I include it here is that very, very early on in the course of something like toxic epidermal necrolysis, which is usually a very severe drug reaction, it can look morbilliform. But one clue that this is not just your run-of-the-mill morbilliform eruption is that the skin is very painful, not itchy, but painful. Like can't even put the sheets on painful. And it starts to look kind of gray or purple in appearance rather than pink. Sometimes your viral exanthems can get a little bit gray in the center, but if someone says, my skin hurts so badly and it starts to look gray, that's when you really need to be concerned about this patient.
And that's also when I'll look for that mucosal involvement, right?
Exactly.
That's part of, you're not going to get mucosal involvement necessarily with viral exanthems unless you may have some aphthous ulcers, et cetera.
Right.
But it's really that kind of really significant mucosal involvement.